I am so sorry, but there's no heartbeat. I am so sorry, but the baby has stopped developing and we need to talk about what's next. If you've heard these words at your pregnancy checkup, I am deeply and sincerely sorry. This episode is about what's next. We will take a deep dive into what exactly a missed miscarriage is and what options are available to you. This is a tough topic, but it's so very important to know what your options are, to know what questions to ask your doctor, because you typically do have options for what to do next. And you need to know what questions to ask in order to decide what is best for you. Welcome to Baby or Bust, the fertility podcast with interviews and in-depth discussions on reproductive health, created to support anyone curious about infertility, miscarriage, and early pregnancy. I'm your host, Dr. Lora Shahine, a double board-certified OBGYN and reproductive endocrinologist, and former fertility and IVF patient myself, helping to build families for almost 20 years and dedicated to supporting and educating you on your family-building journey. Take a moment to give us a 5-star review. It means so much. It helps people truly find the show. If you have been diagnosed with a miscarriage and you are grieving, I am so sorry for your loss. You need to hear, number one, that miscarriage was not your fault. And number two, you did nothing wrong. Part of counseling after the diagnosis is what next? And that's what we're going to talk about. We will go through what a missed miscarriage is, what options are available to you for resolution, and how to move forward when you're ready. Number one, what is a missed miscarriage and how is it diagnosed? Number two, what are the options for resolution? We will go through the pros and cons of expectant management, which just means waiting to see if the body takes care of the pregnancy on its own. We'll go through medical management. That means taking pills in order to help the process. And we'll go through surgical option or a dilation and curettage. And I'll leave you with some questions to ask your doctor. And finally, some resources. So let's get started. Topic number one, what is a missed miscarriage? So what this means is you are pregnant, but the pregnancy is no longer developing. Sometimes people have spotting and cramping and they go to the doctor and they're told, okay, the pregnancy is not developing. There was a heartbeat last time we saw you, but there's no heartbeat. And then sometimes people have what's called a silent miscarriage, and it's devastating. They're still having symptoms, maybe like nausea, breast tenderness, moodiness. They feel pregnant, but they go in for a checkup and there's no heartbeat. Maybe they should be 10 to 12 weeks along by their last menstrual period, but the pregnancy is measuring 6 or 7 weeks along. That means that the pregnancy really stopped developing around 6 or 7 weeks, and the body just hasn't gotten the message yet. And so this is called a missed miscarriage or a silent miscarriage. Basically, you're pregnant, but the pregnancy is still in the uterus, and you're thinking to yourself and talking to your doctor about what to do next. This most often happens in the first trimester. This diagnosis is also called a missed abortion. And that's important. It can get confusing if you see the word abortion in your billing information or in your medical records. Abortion is a medical term, and it just means that the pregnancy stopped developing. I know in society that it has become to mean something emotional and like an intentional termination of the pregnancy, but the word abortion could be seen in your medical records or your billing information, and I just don't want that to cause stress. I see that happen with my own patients, and I do have a video here on YouTube that really goes through the definitions of miscarriage and why you might see the word abortion in some of your medical records. There are other terms for miscarriage. A threatened miscarriage or threatened abortion means that the pregnancy is fine, there's a heartbeat, it's growing, but you're spotting or cramping. It's called a threatened miscarriage. Another is a spontaneous miscarriage, also sometimes called a complete miscarriage or complete abortion. That means that you have passed the pregnancy, it's out of the uterus, it's finished, but you're being seen, by your doctor or being cared for because you had a miscarriage and now it's complete. There are 3 options that you can proceed once you have a diagnosis of a missed miscarriage: expectant management, medical management, or surgical management. Expectant management, we'll talk about that first. That means you are not doing anything active, like taking medication or having a procedure. You're just waiting to see if your body will get the signal that this is not a viable pregnancy, and your body will pass it on its own. There are pros and cons to this. Pros are sometimes patients really want their body to do this on their own. It feels natural to them. They're not in a hurry. They just want to wait and see what happens. And for some people, it's a real pro to not have any intervention. That's a really personal choice. The cons of expectant management are, for some people, this can be emotionally challenging to be pregnant, but not pregnant and kind of waiting for this miscarriage to happen. That leads into another con is you can't really predict when it's going to happen. So it can happen when you're on a plane. If you're a caregiver for a young child or someone else, it could happen when you really need to be doing something else. And a con is too, you can never really predict exactly how much bleeding or how much cramping is going to happen, or what you need in that moment as far as recovery and sort of time to yourself. So there are definitely pros and cons to expected management. One theoretical risk that I was taught to think about in my medical training was the longer that the pregnancy tissue is in the uterus, the higher the risk of infection. One study by Kastakar et al. Said there was a less than 2% chance of miscarriage if the pregnancy is in place for more than 2 weeks after the initial diagnosis. So I think there's less of a worry about infection, but it is important to stay in touch with your doctor. And if you get the diagnosis and you have not passed the pregnancy within 1 to 2 weeks, it's really important to check in. Option number 2, medical management of a miscarriage. And this involves 1 or 2 medications. The most common medication used to medically help pregnancy resolve is called misoprostol. It is a prostaglandin. It's actually approved by the FDA to help with stomach ulcers, but has been used in obstetrics and gynecology to help soften the cervix. It can be used to help induce labor. It helps the uterus contract for that reason, but it can be used in a missed miscarriage to do those exact same things, soften the uterus and help the uterus contract to expel the pregnancy. Now, another medication that is often used in conjunction with misoprostol to help a missed miscarriage resolve is called mifepristone, or RU486, or Miffy. And this is a medication that is typically taken about 24 hours before the misoprostol. And what it does, it's a progesterone blocker, and it helps the pregnancy stop getting that progesterone to support it so that it can respond to the misoprostol and help complete the pregnancy. I know this is hard to talk about. If this is a highly desired pregnancy, and I don't mean to get so medical, I am a doctor, so I do need to talk to people about like, okay, these are the options and this is the medicines, this is what they do. But I also do remember that this is such an emotional thing. I really don't force people to make a decision right in the moment, especially if someone's diagnosed with a missed miscarriage. Oh my gosh, they had a really reassuring ultrasound around 6.5, 7 weeks with fetal cardiac activity. Everything was looking good. And they come back a couple of weeks later at their 8.5-week visit, and there's no more heartbeat, and the baby didn't continue to develop. If they haven't had any spotting, any cramping, any warning signs, it is a shock. And so if I make that diagnosis right then, I'm saying, this miscarriage is not your fault. You did nothing wrong. I do want to briefly talk to you about options, expectant management, medical management, surgical management, but I do not expect you to make a decision. Here is a handout where you can read about it more, and we're going to check in with you tomorrow to see how you're feeling and how you might want to move forward. I just always remember that patients are sometimes in such shock at the diagnosis that they can't hear anything that I say. And medical or surgical or expectant management, if someone is not actively bleeding or, heavily, if they don't have any signs of infection, there's no rush to make this decision. Sometimes people even just need to repeat the ultrasound in a few days or a week just to wrap their head around the fact, like, is this really happening? So there's not a medical urgency unless there's really heavy bleeding or infection. And you can typically take some time to make this decision. Back to the medical management. The way it works is misoprostol is typically given in a single 800 microgram dose that's actually placed vaginally. And within a couple of hours, people will report cramping and bleeding. If you don't have any reaction to that first dose, you can often repeat the dose. And if somebody's using mifepristone, they'll typically do that about 24 hours before they use the misoprostol. Misoprostol can be given orally, but a lot of people will have pretty heavy diarrhea if they give it orally and some other side effects. So a lot of times it's given vaginally. One randomized controlled trial by Zhang et al. In the New England Journal of Medicine showed about a 70% chance of success with a single dose of misoprostol. And if somebody needed a second dose, the success rate was over 80%. And by success, I mean passing the pregnancy completely and not needing to have a surgical DNC in order to complete the resolution of the pregnancy. A lot of providers will just use misoprostol, but there is a randomized controlled trial by Schneider et al., also in the New England Journal of Medicine, showing that a combination of mifepristone followed by misoprostol has a significantly higher effectiveness rate or success rate and a significantly lower need for a surgical intervention or DNC. The full protocol of a medical management of miscarriage is on the American College of Obstetrics and Gynecologists website. The protocol includes a couple of important points that the patients need to be counseled about when to call, like when is too much bleeding or too much pain. They need to be able to get access to somebody on call at night. They need to be able to know to go to urgent care or emergency room if they're needed. And the general guideline is soaking 2 maxi pads for 2 consecutive hours. That's too much bleeding. You should really call someone. ACOG also recommends following up after people feel that they've completed the miscarriage to confirm it with an ultrasound, or if you don't have access to an ultrasound easily in clinic, you could do serial pregnancy tests like blood tests, beta HCG levels to make sure that resolution is happening. So the pros and cons of the medical management of a missed miscarriage are pros. You can time the loss on your timeline as opposed to just waiting for your body to start bleeding and cramping. With the medication, you can plan for an afternoon or an evening, take the medication, just kind of know that you need to be able to rest and just take really good care of yourself. Another pro is that some people don't want a surgical intervention, but they also don't want to just wait around, and the medical management is somewhere in between. Another pro is that for some people, it's important to have the loss in their own home, in their own time, and on their own terms. Cons of medical management is it may not work. There's some times where that first dose of medication doesn't work. The second dose, like you just don't pass the pregnancy with the medical treatment that we have available to us. And then sometimes people really have a lot of bleeding and cramping, and they're just convinced that they've passed the pregnancy, but they have that follow-up ultrasound and they actually haven't. So a big con is that, sometimes up to 20% of the time, it just doesn't work. And another con is it's really hard to counsel somebody about what their experience is going to be like. It can be significantly heavy bleeding and pain. And I've sometimes had patients come back to me and say, if I had known that I was going to have an experience like that, I would not have done that. I would have done surgical management. I've had other times where people say, it wasn't that bad. It just felt like a heavy period to me. And I'm so glad that I was able to do this at home without surgical intervention. So it's very personalized, but it's hard to know exactly what your experience would be like. Okay, and our third option, surgical management of a missed miscarriage or a DNC. This stands for dilation and curettage. And what it means is to gently dilate the cervix so you're able to introduce an instrument into the uterine cavity to remove the pregnancy in a gentle and safe manner. The pros of a DNC is that you know exactly when it's going to happen. You can plan for it. You're not waiting for a miscarriage to happen, or you're not taking medication and then waiting. You can plan for it, and you know that you're going to leave there with resolution. Another pro is there's typically no heavy cramping or bleeding after a D&C at home. Most people might have a little light spotting or a little bit of light cramping, but the pregnancy is really resolved. Another pro is it's easy to collect pregnancy tissue if you want to do genetic screening on the embryos. So chromosome imbalance is the most common cause of first trimester miscarriage. And if you collect the tissue, you can actually test for that. And you can collect tissue at home and bring it into the clinic for testing in certain circumstances. But for some circumstances and for some people, the best way to be sure that they get the tissue to test for the highest chance that they can get an answer is to do surgical management of the miscarriage, to be able to collect it and send it to the lab right away. Another pro is that this can be done with sedation. This is an important point. In my clinic and everywhere I have practiced, a D&C is done for patients when they are completely asleep, kind of like we do egg retrievals. We give a little bit of fentanyl to help with cramping and pain, and we give a medication called propofol that really makes people asleep, a deep sleep for about 10 or 15 minutes. I go into a really deep discussion on pain control for egg retrievals when I do my reaction video, and I'm reflecting on that podcast called The Retrievals, in which some women at a fertility clinic did not receive pain medication because a nurse was switching out the medication for personal use. So if you really want to deep dive into the type of pain control that can happen for certain gynecology procedures, like an egg retrieval or a D&C, watch that video. What I provide is going to sleep and waking up in the recovery room and going home and resting and relaxing the rest of the afternoon. Now, that is not the case in every situation. So some providers don't have access to a surgical suite or anesthesia and sedation to provide for patients. So they will offer manual suction, emptying of the uterus, in clinic, maybe with Motrin, maybe with a little bit of Valium, but that can be really hard for some people. Some people love that. Some people don't want to go to sleep. They're really nervous about sedation. And then other people didn't even know that D&Cs could be done with sedation and asleep. And especially if you have a history of sexual assault, trauma, PTSD, I think doing that procedure without full sedation could be really, really difficult. So please talk to your provider about what options are available to you. Another pro of a D&C is sometimes it's really not medically safe for people to do expectant management or to have medical management of a missed miscarriage because they might have a bleeding disorder, cardiovascular disease, something that if they were to start bleeding too heavily at home, it might be actually quite dangerous. So there are some people where medically they really should do a surgical intervention in a controlled environment where they're safe. Cons of surgical management are, again, some people don't want to do sedation or sedation is not available to them and they don't want to have an intervention without full sedation. Some people really worry about scarring. And I know in my practice, we use gentle suction curettage and we do an ultrasound before and after to confirm that we are getting pregnancy, but only pregnancy tissue or very gentle. The traditional curettage procedure before suction was available was using a metal instrument that really was curetting or really scrape the inside of the uterus to make sure that it's empty. And so you can talk to your doctor about their techniques and what tools that they use. But any miscarriage can actually result in scarring, whether you have expectant management, medical management, or surgical intervention. And if the D&C is done gently and correctly, there's not an increased risk of scarring. And again, a con, I think, is to just not be fully aware of the type of sedation or whether you're going to get any sedation or not. So just full transparency and just have your expectations met. So the third part is, how do you decide? How do patients figure out what they want to do? Every patient is unique. Every pregnancy is unique. I talk to patients about these pros and cons that I just talked about with you. I will say that for people who have had a baby before or their cervix has been dilated before, the medical management or expectant management can be easier for people that have never had a baby or never had their cervix dilated. Sometimes passing a pregnancy, especially if it's later in the first trimester, can have a lot of heavy bleeding and a lot of cramping. That's something to think about. And then also history of PTSD or trauma, maybe just wanting to really completely go to sleep and then wake up and rest at home the rest of the day. Sometimes people really appreciate that option. So it really is patient dependent, but I do have some questions that you can ask your provider to help that discussion and help you advocate for your own care and help you make that decision. So here are these questions and also kind of really good points. So maybe you want to write these down. So questions for your doctor. Number one, what options are available to me? You might have medical reasons that you shouldn't do expectant management, or you need to learn about what sedation options are available to you if you choose surgical management. Number two, if expectant management, ask your doctor, how do I get in touch with the team with questions that I have? How long should we do expectant management? Like, when do I check in again? Number three, if medical management, ask about a prescription for pain medication and also ask about how you get in touch with somebody after hours, or how do you stay in touch with the clinic with the questions that you might have. Number four, if you're choosing surgical management, ask about sedation, ask about pain control. Number five, ask about testing for chromosome imbalance. That's the most common cause of a first trimester miscarriage. And some people don't know that they can get this test done. Sometimes providers they're focused on so many other things. They might not mean to not bring it up, but sometimes people look backwards and say, oh, I wish I had that information. Number six, ask about RhoGAM. If your blood type is Rh negative, so that means like A negative, O negative, then you should talk to your doctor about getting RhoGAM. I think it's better to be safe than sorry. RhoGAM helps decrease the risk of sensitizing to Rh positive blood type if the pregnancy that you have has that. And it doesn't impact the current miscarriage or the current pregnancy, but if you're sensitized, then it could affect outcomes with a future pregnancy. So ask about RhoGAM. And finally, number seven, ask about a follow-up visit. We sometimes just focus so much on resolution of the pregnancy, but you should have a follow-up visit a couple of weeks after your miscarriage, where you've had some time to grieve, you've had some time to think through questions, and you need a follow-up visit where you can talk to your doctor about all of your questions. Why did this happen? Are there any tests that I should do? When can I start trying again? And then patients often ask me, hey, am I more fertile after I've had a miscarriage? Check out my playlist on early pregnancy and miscarriage. There's a lot of good videos there. Some other resources for you. I'm an author, and the second book that I wrote is called Not Broken, An Approachable Guide to Miscarriage and Recurrent Pregnancy Loss. I was looking for a book to be able to give my patients to answer, what tests are we doing if you've had more than one miscarriage? What is recurrent pregnancy loss? What treatments are available? What's controversial? What about men? What about emotional wellness? And so I couldn't find what I wanted to give my patients. And so I wrote it. And so you can find it on Amazon. It's not too overwhelming. It's just straightforward, and it can be a really good resource to have really in-depth conversations with your provider. Why are they doing this test? Why are they not doing this different test? What treatment options are available? So I hope that book is helpful. And then I did a companion book, Not Broken, illustrated. And so the reason I did this, it's basically like a card or a booklet that is basically, you could give it to someone that has had a miscarriage and you're not really sure what to say. And it basically, these gorgeous pictures, you're pregnant, you're so excited. And then when you get diagnosed with a miscarriage, you feel shattered. It's like the image is like the bowl is broken. And with support, with time, you slowly get back together, you heal, and it's a reminder that you are not broken. And then there's some resources in the back for healing and for emotional support. So I really hope that those resources are helpful. Again, I just want to emphasize that if you have been diagnosed with a miscarriage, it is not your fault. You did nothing wrong and you are not broken. And I really hope that you have the strength to not only recover physically, but also emotionally. I want to remind you that people who have miscarriages are getting pregnant. There's a lot of things that are going right. And the most likely outcome is that you will have the family that you dream of, if that's what you want. I hope you really learned something from this episode. It is such a tough diagnosis to hear that you have a missed miscarriage, but I hope that you are taking away points and questions to be able to advocate for your care, to know what your next best step is. Find this episode and all others at my website, drlorashahine.com. You can find me on YouTube, Instagram, TikTok. I love educating. Please send us an email to hello@drlorashahine.com. We'd love to hear ideas that you have for the show, people you'd love us to interview, anything you'd like us to cover. Thank you to our friends at Seattle Sperm Bank and Braze Runs Production for sponsoring the show. Thank you to my producer, Shannon Perry, and her team at Audiotocracy. This is your host, Dr. Lora Shahine, and see you next week. Until then, wishing you love, luck, and pineapples.